Good afternoon, everyone.
Good afternoon.
We're so glad to have you here. This presentation is timely and important for our community and for so many of us. And I want to thank Dave Eckhardt, who has been vice chair of the Health and Wellness Committee for 3 years. And he's going to share a lot of information he has learned through a personal and family journey with dementia, and also for the support of Dr. Heck, who many of you may know as a former CEO of MAHEC, and since his semi-retirement, he is practicing 2 days a week here at Deerfield. So with all of his years of clinical trial support, we are so glad to have him here and working with Dave.
No. Bring me the mic.
We are testing, and actually I am live. So. Thank you, Pat. This presentation is dedicated to all of the caregivers at Deerfield who join us today and who may join us electronically at a later date. In most cases, unfortunately, they're the real victims. There will be 3 topics. 5 cases in my life, the study and clinical trial, and emerging drugs with Dr. Heck commenting. Unfortunately, the trial, we learned a lot. And of course, with the inquiring minds at Deerfield, there will be questions and answers, even if we get shooed into the lobby for the next year. In considering Alzheimer's/dementia, Lily has done a lot of work, and the first part of this is looking at the genetics. Each parent gives us genes, and the genes of interest today are the E2, E3, and E4 genes. If you're unlucky enough to get 2 E4 genes, as did a number of my ancestors, that means your probability of getting the disease is about 60%. Of course, diet, lifestyle, environment can move that needle up or down a little bit, but the baseline is about 60%. If you won the lottery and got the right parents, it could be as low as 10%. Again, modified by lifestyle, diet, yada, yada. Unfortunately, cardiovascular disease can be a hitchhiker. Many of the same people who have Alzheimer's had cardiovascular disease, and 4 of my ancestors had dementia, and all 4 are thought to have had related cardiovascular disease, 3 of them congestive heart failure. The first patient is my maternal grandmother. She was born about 1885. Wonderful grandmother. A little bit eccentric, just like the rest of the family. And led a very privileged life. At 5 years old, she made me lunch and went to the top of her repertoire. Sliced chicken sandwich, unbuttered, and white bread, Wonder Bread. And I can't recall whether it was ice water or milk. And she also mastered coffee and tea, but for most of her life, dinner was making reservations, way ahead of her time. The privileged life continued after diagnosis at about age 80. Life was a party, and she was the guest of honor. And having dementia didn't really slow her down, didn't really interfere with her enjoyment of life. You know, made the usual comments, is that woman's fat. Who in their right mind would pick out a dress that looked like that? Yada, yada, yada. And the 7 grandchildren regarded grandma as, quote unquote, as healthy as a horse and as nutty as a fruitcake. She liked everyone, was easy to get along with, and her older daughter took care of her. She passed at age 95, in her daughter's arms, watching Lawrence Welk, of course. Now, if you offer me that contract, I'll take it right now. Age 95, in my daughter's arms, watching Lawrence Welk. The next culprit in this play is oh, excuse me, I'm supposed to push the button. My coach didn't. My coach was asleep at the switch. Genetics means that my grandfather was involved. He was an only child. Both parents died young. He died at age 80 of other causes, which gives the sleuths absolutely no clues, but he is presumed to have been double E4, just as the rest of the ancestors we talk about this afternoon. The other thing is that all the men involved in this play are MIT grads, so, you know, it's not lack of education. So, as we said, my grandfather, no symptoms, died at a relatively old age. His first daughter is the next on the list. Had a difficult life. Like many of her siblings, was first diagnosed about age 78. Quietly accepted the disease, was mildly disappointed. She exchanged room and board for 3 young career women in her large house, and someone was always there to take care of her. That worked out pretty good. She led a very good life. We all gathered around. It was sort of acceptable, disappointing but acceptable. Last 2 to 3 weeks of her life was in a hospital where she was formally diagnosed with having progressive congestive heart failure. Just added to the list. Third patient was my mom, closest to home.
Change.
I can be trained. First noted at age 78. She pretty much expected this based on family history, was deeply disappointed. Her worst fear in life was living in skilled nursing, i.e. a nursing home. She told us that every time we would listen, starting at age 70. And to her chagrin, it happened. We started with home health care. When she became incontinent and nonverbal, moved to the skilled nursing, and she really felt trapped within herself. Karen's, among Karen's, my wife's last words to her is, "Lois, things will all be all right." And the last words were for her, "They will not be." And as we often find with Alzheimer's patients, you never know what's going to strike their fancy, so you keep trying. And my dad was accused of administering narcotics without a license for his 2-hour session of a seaside ride around Fort Myers Beach and environs, and feeding her dinner. And then when visiting, we would go off and have dinner together. But that was really the only thing that made Mom smile. Got the right one. The lesson that the 3 children had was we worked hard with Dad, and time again said, we are here to make sure there is only one patient. You take care of Mom and we will take care of you. We helped interview and hire in-home providers. We went out and identified the skilled nursing facility with him. We attended a support group when he was when we were in town, which he found very helpful. We pre-selected a skilled nursing facility. We were there for a respite visit. Mom was going for a respite visit to the skilled nursing facility. and she became incontinent 2 days before we left town. A quick phone call, can you make this permanent? What did you say? Can you make, yes? Could it start on Saturday next week? Yes, it could. What do we need to do? Bring her over on Saturday next week. There's a couple of papers to sign and 3 signatures will do it. Everybody exhale together. The other story of this was my folks were among the first to buy long-term care insurance. So we keep telling my dad, file the forms. No, why not? They're not gonna pay. So this dialogue went on for about 6 months, and then we said, okay, new deal. We will fill out the forms. There are 3 spots where you need to sign. Will you sign in the 3 spots and let us take care of the rest? Of course I would. And do I get 10% of the first check? Yes, you do. And of course, you know, this dragged out over 6 weeks. We called him and, sir, we're working on it. No, another one. So he called up one evening. First check's here. Do I get my 10%? No. Why? Well, the first check was $39,000 and change. You don't get 10% of $39,000 and change. See, we told you should file. Fourth patient is the youngest child. And here we're see a person who served in the U.S. Army during World War II. Again, diagnosed at age 78. Good rapport with his family to the end. All 4 of his children lived within a 15 to 60-minute drive and visited often. He was resigned to the disease, but mildly disappointed throughout. I moved to a skilled nursing facility when predeceased by his wife. Again, died about age 86, and having everybody close by and visiting helped immensely. Okay, and the 5th patient is Jim Jones. This was the guy that we mentioned in Writer's Read when asked by his wife, what time is it? Looked out the window over the North Pacific and said, not only do I not know what time it is, I don't even know what day it is. Early onset is ugly. This person was first diagnosed at about age 56, maybe just 57. Disease progressed very quickly compared to standard age onset. This is ugly is the best word for it. I stopped seeing him when he didn't want to see me. And as best we can tell, he thought I was coming to Fort Myers to try and steal his wife, not understanding that one wife is more than enough for me. Died at age 60 and unfortunately lost touch with his wife and family. As I know, he was about a half mile from my folks in Fort Myers, so any type of Fort Myers included both. And this was a very, very difficult for his family. But then again, Alzheimer's and dementia is very difficult for all of us, particularly when we have a family member. One button. Some conclusions as we are finding out is that each case is different. To me, the thing that is surprising from seeing 5 family members afflicted and close ones was that each case was different. And even each patient can be different, you know. I could eat a grilled cheese and tuna melt every day for 35 years, and as a patient, decide tomorrow at noontime I'm never going to have one again. I could swear up and down that I last took art when I was in junior high school, and I swore I wasn't going to do it again. But with its Alzheimer's, that's the best thing ever, that happens to me every week, and I can't wait to get back there. Michelle does a wonderful job. Let me go tomorrow, but it doesn't meet tomorrow. Oh well. Okay. As we discussed, many patients can enjoy certain portions of life with the disease. And we just have to keep searching. Caregiving is a tremendous burden. Each of us in the room can help. Okay, and how you can help is if you have somebody you know who's a caregiver, stop and spend a couple of extra minutes with them. Like, how are you doing today? Or nice to see you again. And it could be that you get a sob story about how difficult the last 24 hours, but that's our Christian responsibility to listen to people who are distressed by what they're going through. And in a moment of weakness, a couple years ago, I told some of the caregivers, you can give me a call 24/7 if you're running up against difficulties, and I'm here to respond. Just understand that at the first 2 minutes after midnight may not be quite as good as the rest of the conversation. In 3 years, from 7 people, 21 man years, total number of calls received, 0. But each of these people think I'm a wonderful person for offering, so I'm going to keep offering, and I'll let you all know when I receive the first phone call, should it be in this lifetime. Genetic testing is predictive. I have had genetic testing. I know of one other anonymous person in the audience who has had genetic testing, and this puts your mind at ease. Most of us find it helpful to know what our status is, but some of us would prefer not to. This kind of brings us to the close of the first part. We have time for 2-3 questions if we would like, or comments. Don't everybody speak at once. Time's up. Okay, please go. Gary, go.
Go. Who's got it? No, I'm holding the mic here.
Okay.
Anybody who wants to talk?
I must have put everybody to sleep. Okay, let's move on to the clinical trial. As an introduction, I forgot to put the stringer on my finger, sorry. I have received tremendous support from Dr. Heck and the Deerfield team, including Steve Jones, Angie Bennett, and Delana Davis. It's just been pleasantly surprising and wonderful to work with, and this could not have happened at a better place. CBS sends me periodic ads, most of which end up in the electronic trash bin. But one of them asked for volunteers to participate in a clinical trial of a potential Alzheimer's drug. So based on my family history, I felt a ethical obligation to participate. Had a little counseling with Dr. Heck as I wandered in. Qualification were ages 65 to 80. Birth certificate check. Pal positive by blood testing, although it took 6 months to arrive at the conclusion. We got there, and I qualified. No dementia is determined by 5 to 6 hours of interviews and testing, ruling, but I passed again. No brain abnormalities by MRI, although my family would choose to differ with you that I do have abnormalities, but that's because I'm an engineer, not because they're on the MRI. The planned clinical trial is an infusion 9-tol every 28 days, starting on the 17th of August. Health checks concurrent, cognitive evaluations at the start every 6 months, and a study expected to run 5 years. The unpublished reason for the lengthy study is it's wonderful if it delays the onset for 3 months, but not economically viable. On the other hand, if it delays onset by 5 years, you have a license to steal as a pharma company. So we plan to do that. Each infusion looks like driving over there, 15-20 minute drive from the parking lot. Health check for 20-25 minutes. Then we order the infusion material, and that takes a half hour of infusion. Then an observation period. And door to door, it's at there somewhere between, as little as an hour and 55, sometimes as long as 2 3/4 hours. And if you do the full study, it's, 9 times 2.5 hours, a number of hours. Well, let's find out what happened in the real world. Actual trial for me ended after the 5th infusion. Too many. Expert have deleted. Side effects, which have become injuries. An acute reaction mimicking a heart attack to the 5th infusion. Health checks ended in March of 24, and no adequate cognitive evaluations. Although my attending neurologist ran an evaluation in November of 24 and concluded I have beat my relatives by 2 years now, I have no identifiable effects of dementia, whereas 4 of them and 1 friend did. So, 1 for the home team. Side effects. We could talk about side effects. I take the first half hour, Dr. Heck would take the second half hour. And want to thank that there were some personality disorders that were reported to Steve Jones and then to Dr. Heck. And I want to thank those of my friends who truly reported them and added to the body of evidence. And we had already stopped the drug, and the personality disorder mostly improved over the next 60 days, but we're ready for the next slide. And this is the first half of the list, just the highlights. There's another 6 that this is a family audience, so we're not going to discuss the rest of them. Early study conclusion: infusions ended, participation studies, inadequate support, and the principal investigator and the whole gang. So it turned into a sort of an 18-month ordeal. In one of the early documents, I referred to this as cruel and inhuman treatment from a drug company. And now the bad part. Side effects have worsened since August of 24 and now considered long-term injuries. Dr. Heck, wave your hand, is now the de facto principal investigator, and I'm now the de facto case manager, neither of which either of us wanted to do. And there are ongoing dialogues with the sponsor, ethics, blah, 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 blah. We don't want to talk about it. In any clinical trial, there are participant protections, and the slides will be posted, the video will be posted. AME Code of Ethics requires informed consent. What is special about a clinical trial is on day 1, we know some side effects. New ones may develop by day 90 or day 180 or day 270, and some of them could be fatal, and the folks doing the studies don't always know enough to tell you about them. Number 2, the FDA has good clinical practice recommendations which should be followed, which govern the conduct of the sponsor and the principal investigator. As a chemical engineer, good facility design practices are considered to be standards and followed religiously. Sponsor policy and code of ethics, see website. An ombudsman to represent you, And tort law suggests that we mitigate all injuries. My team, the Mighty Casey, struck out on all 5. But, here we go. Lessons, enter studies and clinical trials cautiously. I omitted a word, very, underlined. Seek guidance from your PCP. He attests to the fact I did. And not all clinical trials turn out well for the volunteers. We are at the edge of this section. Would you like to make a comment?
No, I mean, right up front?
Yeah.
Got like a few more remarks to make, yeah. Come on.
And then he'll make a couple of comments, then he has some comments of his own on the new drugs.
So thank you, Dave. It was very fun to participate with him in the trial because he was so engaged and lots of questions and knew a lot of the data and looked things up. I am not an expert in this class of drugs. They're new drugs. I have had experience as a researcher myself. I have had 2 careers, one University of Cincinnati, the School of Medicine, where I did a lot of research in global health and public health and nutrition. I actually worked at the World Health Organization. Oh, I don't have any slides, so I'm good.
Okay, fine.
Yeah, I stopped making slides when I retired. So I've had a lot of clinical experience doing research, and then what's interesting to me as a doctor, which is all I do basically now, is I love reading original research and trying to make sense out of the statistics to decide whether it's relevant for you as my patient. And that is actually an important art, and for any of those who have a math background, it's very challenging to read on the internet information about a clinical drug trial and then understand whether it's right for you. And I'm going to actually give you an example through about this drug in particular, but also its predecessors. The drug that Dave was on was donanemab, which is a monoclonal antibody which attaches to the amyloid proteins and the tau proteins. And it basically is thought that those, because they're always present in Alzheimer's dementia, that if you can develop your own antibodies that attach to it, gobble it up, get rid of it, then that might be the cure. We don't have any evidence of that yet, but that was the theory behind developing these drugs. And I have to applaud, all the basic science that was done around this, because this is a thing that concerns all of us as we start to grow gray hair, that you don't want to develop dementia if you don't have to. So these drugs are important. When you do just an internet search, you'll come up with the statement that we'll use donanemab, the Trailblazer Trial 2. It was the predecessor to the one that Dave was on. It'll say that donanemab decreases the progression of dementia by 32% compared to placebo. That sounds pretty good, but it does not mean, it's actually not that good. It does not mean that what happens is my loved one, now instead of having to remind him 3 times about what we're going to do today, I only have to remind him twice. What they did in the study is they used as the endpoint, they looked at the decline of cognitive function over time, only a year and a half. And what they found was, on a 140-point scale, that the group taking a placebo actually declined by about 10 points. The group taking donanemab infusions declined by about 6 points. So, I'm sorry, yes, by about 6 points. That's on a 140-point scale. So if you remember, like those of you who have done our MOCA exams, we have 30 points. This is 4 times that number of questions. And the decline is actually so minimal that patients can't perceive a difference. Neither can loved ones. The same was true with the lecanemab study. And also what we don't know, also what we do know is that that decline occurs in both the placebo group and in the study group. So if you are taking this drug, you will still decline, but you will decline perhaps at a hopefully perceptible rate, but maybe not perceptible rate. So the Trailblazer 2 study was actually published, I believe, after you signed up for the study, and is published in JAMA. And from a statistical standpoint, this is the classic flaw of looking at the relative improvement versus the absolute improvement. So when you're reading studies, you really want to look at, well, how big was that clinical difference? And as a physician, I've looked at the Trailblazer study and a large meta-analysis of all 3 drugs, the trials, and have decided that I'm not ready to recommend this to my patients yet. So I would recommend it if it was as simple as, for example, taking Tylenol, which is safe. This drug has real side effects. These drugs have 2 major discernible, actually 3 in the Trailblazer study, 3 discernible side effects. Number 1 is they develop these things called amyloid-related imaging abnormalities. And if you want to look at it, it's basically a brain bleed that occurs in study subjects. We don't know the clinical significance. Some of those people are asymptomatic. Some may be having this wide array of symptoms related to that because the brain is so complicated. The second adverse effect that is important is that there was a relative decrease in the brain volume in this people taking the study drug as compared to the placebo. Again, we know that on MRIs, when you look at MRIs on taking care of patients, if there's a decrease in brain volume, we worry that they may have some problem with dementia. So I don't like that idea either. And the third thing about the Trailblazer trial is, Trailblazer 2, is 3 of the patients died in the study. So I know this may sound disappointing to some of you who think, great, things are going to be better. Let's take the hopeful side. The hopeful side is these drugs are probably the progenitors of the drugs that will be helpful. And so I think people like Dave, who was willing to undergo a clinical trial in order to help improve science move along. In this case, I believe what's going to happen in these longer trials is going to say, yeah, there's some improvement, but not enough to warrant it, taking it. But the next drug coming along may have the benefit or more benefit and less adverse effects. So right now, the first country to really rule definitively on this is England. The Great Britain has a National Health Service. The drug was approved by their regulatory body, but the National Health Service says, we're not paying $36,000 for such minimal, a year for such minimal improvement. So that drug is not available. And Medicare right now is apparently just paying for those who are in drug trials. But the drug trials are generally sponsored and paid for by the drug company anyway, so it's a pretty safe thing for Medicare, I guess. So the other positive thing is, he's a great example, actually, that he's got not so favorable genetics, but has done things that will help prevent dementia. We don't know all the things that prevent dementia. Those of you who are my patients hear me all the time say, I summarize it really easily. The best thing for you to prevent dementia is to stay physically, socially, and intellectually busy. So if you find yourself watching too much Fox or CNN news, stop that right now. You want to be engaged with people. You want to be engaged with your body. It hurts more to exercise, to be active. I find it increasingly difficult. Every time I exercise, something hurts. But I know it's important, and being socially engaged, it's a good thing. It's why I love having my grandchildren, who are here today. For those of you who couldn't see in the back, I had to pick them up because they're students over at Carolina Day, which is a great school, and they're riding home with me. So let's talk a little bit more about dementia prevention, because I think that's what you should be particularly interested in. In my review, when I have my nighttime awakening, I wake in the middle of the night, I read medical studies because I like to. And then the next morning, I'll get up and over coffee, I'll tell my wife about what I just read. So she's a nurse, and we never seem to run out of things to talk about. So one morning, this is about 10 years ago, I was having my coffee and I said, Kathy, I read in the New England Journal last night that vitamin E may be helpful in preventing dementia. She said, oh really? She said, well, how good are the statistics? I said, well, not great, but worth looking at in more detail. And she said, oh, that sounds interesting. So 2 weeks later, I come to the breakfast table and there's 2 bottles of vitamin E. And I said, oh, you decided to get these 2 bottles of vitamin E, this vitamin E. She said, yeah, I did, but I can't remember what I got them for. So I thought, okay, well, I guess we're starting a slow decline here. But 10 years later, she's good. So let me talk about the things. So there was a large study, a meta-analysis, and I love these studies. So if you're ever reading and you're saying, okay, where can I get really good information? Read a meta-analysis. So what they do is they take good studies, they throw out all the bad ones, and there are a lot of them. They throw all the bad ones out. Good studies from a statistical standpoint, and then they collate them together and make a broader statement about what the body of knowledge speaks about. So these are meta-analysis studies. So there's a meta-analysis study done looking at prevention for dementia in the British Medical Journal. It's only a year old. It's a great study. They actually had, believe it or not, 44,000 studies that they looked at. So I don't know who has the patience to do that, but I don't. But they boiled it down to basically 240 observational trials and 153 of the gold standard, the randomized controlled trial. And they come up with class 1 suggestions, which are ones that have a fair body of evidence that they may be helpful. Class 2, a fair amount of evidence that they, or a less fair amount, but they could also be helpful. And then the last one is, they're not helpful, don't do it. So let's start with the good ones. So if you're interested in writing these down, most of them are intuitive. The first one is good education. So too late, can't go back to college now. But the higher your education, the lower incidence of dementia. Second, cognitive activity. So just what I said, keep your mind active. The third is you have a reasonable body mass index. So you're not very, very overweight. It's okay, I've said this to many of you before, in the elderly, it's okay to be a little round. If you have a flat stomach, you're sick. You're not healthy, because everything that used to be in here is now into here. And you can't have a flat stomach as you get older. It's just very, very difficult. So the third thing is no evidence of an excess of homocysteine. So if you're worried about whether you have a homocysteine, don't go out and ask for a blood test. Just take a B vitamin complex, and that's enough, because B vitamin is what we treat it with. The next thing is depression. Depression increases the risk of dementia. The third is just a high level of stress. So I think particularly people who are poor have a higher incidence of dementia. The third is diabetes, or not the third, it's the sixth or something. The next is head trauma, so that will increase your risk. And then the last two are important. So not having either, a protective thing is not having either high blood pressure or low blood pressure. So either one of those can be risky for people. So the things that were less strong evidence were too much weight loss. It's good to have physical exercise activity, not smoking, sleeping well, no cerebral vascular disease, not being frail, atrial fibrillation. Those are the things that have less good evidence and may be helpful. And then the things that we don't recommend is don't take estrogen therapy if you don't have to later in life, and don't take the acetylcholinesterase inhibitors to prevent diabetes. So that's drugs like Aricept. So if you've heard of Aricept, those are the drugs we've had for a long time. We don't take those preventatively. Those will not help, and they shouldn't be taken preventatively. So I think I'm going to stop there. I could go on and on. I mean, I have a lot of clinical experience with dementia, but I love having an audience that may be even half interested in the statistics, because I like them. And I tell you, you want to have a physician who reads the literature and knows statistics well enough to know whether what they're recommending to you is actually beneficial or not. So.
The tag team is now ready to answer questions, and Gary is going to help. This one back here.
Mark?
Yes, good. Mark.
I would assume it's fairly large pharmaceutical companies that are putting together these trials. The question is, are there not standards that these pharmacies that have to be set up that give some protection to the patient, even though, and again, I mean, it could be people who are, I've seen for people who are dying and they volunteer for heart transplants or things like that, but in your case, you're nowhere near that. So aren't there standards that protect the patient like David?
So, go ahead, you can make
Yes, and that's why we touched on them, because the standards that we thought were there weren't. I.e., if I go to a doctor, I have every right to believe that they will follow the AMA Code of Ethics. If it's a clinical trial, they should follow FDA good clinical practices. If I suffer an injury, they should attempt to treat it. I.e., if I have a side effect, what is the treatment? Go see your PCP. He's not getting paid for it. Go see him. It's your choice.
So I want to just elaborate. Every study in the United States must be reviewed by an institutional review board. So that institutional review board is comprised of individuals who are not part of the study, are not paying for the study, don't have a financial relationship with the investigators. And so their job is to protect the patient. That's all. They're not trying to make sure it's a good study. They're trying to make sure that the patient is protected, the participant is protected. But I would say you brought up another interesting question about, so what is the pharmaceutical company going to make sense out of this? So the Trailblazer study is one of those studies, like many now, that are the principal investigator is Eli Lilly. It's not some independent researcher at Harvard or Duke or someplace like that who wrote a proposal and got it funded by Eli Lilly. It's Eli Lilly who is the principal investigator. And so you have to be, it's one of the reasons why I think reading the statistics matter, because they want the study to be positive. They want you to think that your loved one is going to ask the question, what are we doing today, one time less or two times less than they did before.
Right.
Hi, I've been Dave is my neighbor. We've been talking about this clinical study. and we've done a lot of discovery work. One of the things that Dave did not mention is when you go to start a clinical study, the investigator is obligated to tell you what the side effects might be. And in Dave's case, the doctor did not do that at all. So he went into this thing blind, unfair, and so we'll see where all that goes. It should not happen that way. The other thing that Dave did not mention is his sister is also in this clinical study. And it's obvious that Dave got the drug. It's also obvious that his sister got the placebo. She also had side effects explained to her by her clinical study doctor. Some of the research that we've done, took a look at Eli Lilly's internal documents about what is required of the clinical doctor to do one of these studies. And it's right there in black and white what the clinical doctor is supposed to do. And Eli Lilly has failed to have this doctor adhere to their internal processes. So it's quite an interesting adventure that we're in, and I guess I'll stop from there.
Okay, I guess I have the mic. Listening to Dave's experience, he had horrible side effects that are still are lasting. He had to leave the study because of the bad response. How many other people left the study? How did they ever determine that it was valid if people are dropping by the wayside? And is this drug already on the market?
It is.
And how did that happen?
So every study has to submit had to do an intermittent report to the institutional review board. And having done a lot of these studies, it's a very lengthy process, and you have to be reporting every adverse effect, every person who dropped out of the study. That becomes part of the final report, but it does not. It does not necessarily involve breaking the blind. Sometimes the blind is broken, so they know who has what. There's two reasons they break the blind. One is an inordinate number of adverse effects, more than you would expect by any, not just adverse effects, but serious adverse effects, and it has to be in a statistically significant number. And the second reason to break the blind is if the benefits are so great. They have to break it because the data is already there and people could be benefiting. So that hasn't happened. And I'm sure that Eli Lilly has careful scrutiny in their institutional review board. It would not be Eli Lilly's own institutional board. It'd be somebody else.
But the comment here is just because a drug is approved based on 5,000 patients treated doesn't mean that it will remain approved 2, 3, 5 years from now. If my experience turns out to be one of 100,000, plausible but not likely, it could be a very good drug. If my effects happen 300 times per million, it could be a horrible drug, and there is insufficient information, data, to make that decision. And although the drug is approved, it has not been placed in the formulary, and my neurologist is unable to prescribe it as of 6 weeks ago.
Yeah. So I will give you an admonition about new drugs. This is a great example. New drugs are not always thoroughly vetted. And sometimes we find drugs that get on the market. There's a lot of enthusiasm. They certainly advertise on TV a lot. And then people feel compelled to try it because, oh, this is a great miracle drug. And the next thing you know, we're getting many more reports and the thing comes off the market. I've been in practice for 40 years. I've seen so many things come off the market. So many things that we used to do that I just shudder. That when I was a resident, they would call us down to the emergency room, stat, when somebody had a heart attack. And we would go crazy getting a central line in and giving them IV lidocaine to stop any fatal arrhythmias. Well, 3 or 4 years later, after starting that practice, it was all over the United States. Somebody did a thorough study and determined that lidocaine is actually a pro-arrhythmic, meaning it causes arrhythmias. So we stopped it. But the valuable lesson for you is when you have a doctor who prescribes you an old-fashioned medicine, don't feel like they're just being old-fashioned. They're being prudent. And there's nobody more vulnerable than the group in this room. Well, except Abby and Tilly over there. But we're all vulnerable because we take more medicines, we have more problems, and we have to be really careful about not getting too many meds. We have to be, we need what we need, but not more than that. Oh, we got a question from Abby.
What's the side effect?
What's the side effects? So the side effects can be, well, he talked about his. He was itching. What else did you have?
Headaches,
Bad tastes?
bad taste, new side effects, one of which may have appeared at breakfast this morning. I may have gotten a reaction to peanut butter for the first time. One of my side effects, okay, I need a bone. Chocolate. I can't eat chocolate without getting.
Can you imagine that, Abby? What if you couldn't eat chocolate? Oh, man. Don't take that medicine.
So, Dr. Heck or David, I'm a little confused about the role of the FDA. I thought that if a drug was on the market, that it had to have FDA approval.
It does.
I don't know what approval means. Does that mean that it's not harmful? Does that mean that it's efficacious, or what?
So you have to get FDA approval, and in most of our cases, you have to get approval by Medicare to pay for it. And actually, the commercial insurance companies follow generally what Medicare does. So here's the problem that I think is increasingly evident. The medical community doesn't have as much control over what drugs make it to for FDA approval as they used to, because like new drugs get heavily advertised on television, and patients demand it, and therefore the FDA have been pressured to get out provisional approvals or early approvals of drugs that really aren't yet ready. But, I have to say, some people may be willing to take the gamble for disorders like dementia, and there may be a drug coming in the future. I don't think it's going to be donanemab, but there may be one in the future that would be helpful.
So Eli Lilly could put this drug on the market without FDA approval?
Oh no, they have to have FDA approval. But what I'm saying is, they pressure the public to pressure the FDA, and it becomes political. So we saw that with the drugs for the vaccines for COVID. In this case, it turned out all right, but there was a lot of pressure to give provisional approval for a drug that would be delivered to an awful lot of Americans, and I'm not an anti-vaxxer. I'm telling everybody to get their COVID vaccine. I get all mine. But there was a gamble with that.
I might add a rhetorical question for each of us is the drug I was on has been approved by the FDA, but the manufacturer has yet to decide to market it. It is thought to produce revenue of upwards of $1 billion a year. So the question is, if it has a revenue stream of $1 billion a year and FDA approval, what's the fly in the ointment? He says yes.
Well, and a lot of us as clinicians that take care of people with dementia, we're going to get a lot of pressure by patients to do that.
But when I used to do some statistical analysis, eventually I realized that the larger the sample, the more likely that a small difference is statistically significant, but it may not be terribly useful, which I think was the point you were making with your 33%.
Yes. So again, if there's a drop, if there's a difference by three measurements in a 144-point scale, that can be a statistically significant. But is it clinically significant, and is it, particularly in this case, worth the risk? It's absolute versus relative risk. We frequently use in making clinical decisions, we use a number called the number needed to treat. So you can look up almost many things, like have you used atorvastatin as primary prevention? How many people do you have to treat until one person has a heart attack prevented? And that's about, when you do the statistics, it's about 1 in 240 for primary prevention using a statin. And so then if you also add on to that the number needed to harm, you can get a very good idea from a clinical standpoint. And I would say most good physicians are using that number pretty frequently to make clinical decisions, which is good.
Last chance before I say thank you and roll the credits. We of course want to thank Dr. Heck for his time away from his grandchildren. We want to thank the Health and Wellness Committee, especially the Cognitive Care Committee for standing behind this effort for the last 4 years, and for Deerfield for feeling concerned about cognitive care and remediation. We're all in this together, and thank you for your time this afternoon.